Okay, continuing on with care of the diabetic patient, nutritional needs. A lot of times these patients count their carbs or do carb exchanges. Most of the time they will need a dietary consult with a dietitian who can discuss the different diet regimens that can keep a diabetic's blood sugar intact, in control, along with medication and exercise. They also can talk to them about the effects of alcohol on their blood sugar and how to manage their blood sugar if they choose to have an alcoholic beverage. Nutritional needs continued with considerations for the elderly. Remember, our patients who are elderly have an increased risk of poor nutrition anyway. They have a decreased awareness of both hypoglycemia and hyperglycemia. And let's face it, when our patients are elderly, it's hard to change old habits. So you may not be able to get them to give up their Little Debbie's completely, but maybe you can get them to pick one that has less frosting on it, or maybe only eat a half instead of the whole one. The importance of eating and taking medication at the same time every day. Please see the considerations for the older patient and patient-centered care on page 1300. It is very hard to get them to change habits. When I mentioned the Little Debbie, my father, who has since passed away, who had been obese in his middle years, but as an elderly person was quite thin, but still had to and had been able to come off of most of his medications for his blood sugar, but was controlling it with diet. And one of the ways he controlled it with diet is by sharing his snacks with his basset hound until the vet said that the basset hound needed to lose weight. So old habits are hard, but perhaps there are ways that we can alter those habits to make them more healthy for living with diabetes. Exercise therapy is an essential part of diabetic management, especially for your type 2 diabetics. There are considerations for the elderly. They have other risk factors and they need to increase their activity slowly. Just as an aside, patients with type 1 diabetes should only exercise when their blood sugar is in a certain range, and usually their endocrinologist will come up with what that range is. The range suggested in the book is between 100 to 250, and no ketones in the urine. I'll be honest with you, I just called a friend of mine who is a type 1 diabetic, and I said, 250 just sounds high. And she agreed with that. She said, but most of the time your endocrinologist or your pediatric endocrinologist will come up with what their blood sugar needs to be prior to exercise. That would not be on the test. I just thought it was interesting that the book gave such a broad range, but when I spoke with my friend, and then I spoke with another friend of mine who is a nurse practitioner at a pediatric endocrinologist, and she said it really depends on the type of activity that the patient's doing, but that pediatric endocrinologist or their endocrinologist, if they're an adult, will help them determine what that range needs to be. That would not be on the test, guys. Just thought it was interesting. Patient and family education for self-management with exercise is on chart 64-4. Again, none of the stuff about I just mentioned about type 1 diabetes would be on the exam. I just thought it was interesting. When working with the diabetic patients, it's always important to make sure that we examine and assess their feet. The focused assessment of the diabetic foot is on chart 64-5. That's very important. The foot risk factor categories I'm not so concerned with is in table 64-10. I think it's interesting to look at, but I am interested in the focused assessment of the diabetic foot and the patient education related to diabetic foot care in chart 64-6. You want to make sure that they clean and inspect their feet daily, that they're wearing proper fitting shoes, that they avoid walking barefoot, that they trim their toenails correctly or they see a podiatrist. They need to report all non-healing wounds. And all that sounds well and good, but if you have an obese type 2 diabetic who maybe has a very sedentary lifestyle and bad knees and probably may not have seen the bottom of their feet in a really long time, you're either going to need to make sure that they have a loved one who's going to look at the bottoms of those feet, or you're going to need to make sure that some kind of, you teach them how to use a mirror to look at the bottom of their feet, looking between their toes. So you just need to make sure that when you're teaching someone this, that you not only teach it to them, but you also have them do a return demonstration. And this is a lot of times when you realize that the patient can't get their foot up to look at the bottoms of their feet. So maybe you have to use a mirror, making sure that they can look between their toes, are things that are important when dealing with the diabetic patient and their foot care. A lot of times they'll say, oh yeah, I can do that myself. But a lot of times they truly can't. So that's the reason that it's important not only to have a teach back done, but to have a return demonstration. I kind of usually would use I'll do one foot, you do the other. And that seems to work. I have found it interesting that a lot of podiatrists who specialize in diabetic foot care have started putting nail clinics in their offices, not only for them to trim the toenails, but also where they have like little pedicure stands set up so that they can have their nails done in a safe environment. More information than you want to know about me, but my sister is a diabetic, and I go with her to her diabetic podiatrist because, it's cleaner than most of the nail salons. So if I'm going to get my nails done, that's where I go. Anyway, I think it's interesting that they have kind of found a niche market for the nail salon industry. Not going to be on the test, just thought it was interesting. Okay, care of the diabetic patient with vision changes. The goal of care of the diabetic patient with vision changes is to have no further reduction in vision fields and for them not to have double vision. Keep in mind that the pre-filled insulin syringes and insulin pens are not approved for the use of the adult with vision problems. They do have an apparatus called a count-a-dose insulin meter measuring device so that they can measure out correct amounts of insulin. Sometimes it's just that they can't read the small font on the bottles, so you can have the pharmacy use a larger font, or their home health care nurse can use a color-coded system with their medications. But it's important to make sure that the patient is able to see their medications in order to administer them correctly. You'd be surprised how easy it is to just get a pharmacy to use a larger font on medications. All you really have to do is ask. I thought it was interesting. I kind of brought it up to a pharmacist at CVS one day, caring for a family member, and they said, "Oh yeah, that's no problem. We can just make it bigger." Who knew? So I always like to add that you can always ask the pharmacy to use a larger font on bottles. Again, care of the diabetic patient, reducing the risk of kidney disease. Again, as always, it's good glucose control. The progression to end-stage kidney disease can be delayed or prevented by normalizing both blood glucose and normalizing blood pressure, especially using an ACE inhibitor or an ARB, which protects the kidneys if they have hypertension issues. Another thing that will help to reduce the risk of kidney disease is to stop smoking. When you're working on patients' education for home management, you want to make sure that you go over the signs and symptoms of hyperglycemia. They may realize that something is wrong, but they may not realize immediately that it is a low blood sugar. So it's important to go over the management of hypoglycemia, especially at home, and that is looked at very nicely in chart 64-7. That is, again, management of the hypoglycemic patient at home. When you look at hypoglycemia in the elderly, please see the yellow box on page 1312. The elderly are more prone to complications, including hypoglycemia due to undernutrition, a lot of times they have multiple comorbidities, and they have a lot of polypharmacy, including beta blockers, which can enhance the signs and symptoms of hypoglycemia. But particularly look at the yellow box on page 1312. Care of the diabetic patient, education of home hypoglycemia treatment. Again, we talked about that chart in 64-7. But the good thing to know is that the treatment of the hypoglycemia continues until the blood sugar levels reach and stay in the target range. So it's important to teach the patient not only to monitor their blood sugars while they're getting to that target range, but also to make sure that they're staying there. When blood sugar control is regained, then they need to look back and identify the cause. Did they take their long-acting medication and then not eat? Did they not eat in a timely fashion? What caused their hypoglycemic episode? And that's where they need to identify the cause. But we also want to make sure, and again, that treatment continues not only until blood sugar levels have reached back to the normal range, but also that they stay in that target range. So you want to make sure that you monitor it after they're back at target range as well to make sure that it's staying there. And once their blood sugar is regained, we need to help work with them to identify the cause. Care of the diabetic patient, education for home, preventing DKA at home. Follow the sick day rules. That's in chart 64-9. Again, that's chart 64-9. Big rules of thumb to prevent hyperglycemic episodes at home is to follow the sick day rules, to make sure that you're notifying the provider if their blood sugar exceeds 250 and does not respond to treatment, if they have ketones in their urine for greater than 24 hours, if they are unable to hold down food or liquids, and if they have greater than 2 sick days. These are really important things to keep the patient out of the hospital, so make sure that you do look at those, follow the sick day rules on chart 64-9, and when to notify the provider. As you can tell from this lecture, the care of the diabetic patient, the diabetic teaching is overwhelming. This is not something that is done in a one-time sit down with the diabetic educator in the hospital. It is a multidisciplinary response. It has to deal with not only the endocrinologist, their primary care, it needs to deal with the diabetic educators within the hospital and also at the endocrinologist's office. It may have home health care involved. It is a true team effort to get the patient with diabetes able to care for themselves at home. They need to be able to know and demonstrate their medication regimen. If taking insulin, they need to be able to understand their lag times. They need to understand dietary changes and the reasonings for them. You need to make sure you're watching them perform a glucose monitoring to make sure they're doing it correctly. Again, they need to make sure that they are demonstrating foot care, and they need to know the home treatment for both hypo and hyperglycemia, and make sure they know the rule of the sick days, especially in table 64-15. Again, remember the care of the diabetic patient, their patient education is a multidisciplinary approach, and it's in different places for care. Not only is it in the inpatient setting, but the outpatient setting and perhaps even the home setting, to be able to have these patients have optimal care.